Before we launch into the last section, which is sort of intended to be a pro and con, I just want to ask everyone that when you get an email asking you to fill out a survey, that take a little bit of time and tell us what you liked, what you didn't like about this particular course. Looking at the attendance in the room, I think there's probably a good chance it might happen again next year, and I think we could really be helped with some feedback on how to make it better next time around. And I just want to thank you in advance for the 5 minutes or so you'll take to fill out the survey. Okay, so I've asked a few prominent people to take a stand on a couple of issues. And so as president-elect, I actually gave Dan Smith the hardest of all talks this morning. And he's going to try to argue that notes will not have a significant impact on minimally invasive surgery. So he's going to be our skeptic today.
I don't know whether to thank Dr. Ratner or take him out and beat him up for giving me this assignment. This is a great opportunity, actually, to stand in front of you and talk about this topic. And I will tell you as certain as I am that the sun will come up tomorrow and that the Cincinnati Reds are not going to win the World Series in my lifetime. Notes will not have an impact on minimally invasive surgery as we understand minimally invasive surgery today. Laparoscopic cholecystectomy, laparoscopic ventral hernia repair, these other minimally invasive approaches. Before I go on, let me just be sure about disclosure. Obviously, in a talk like this, the risk that I'm going to have any conflict of interest in anything I say is fairly low. But I am taking considerable personal risk standing in front of this group that I may be jettisoned from NOSCAR. Any industry person in this room who turns to me for any sense of positive feelings about notes will immediately disown me. And you all may find my opinion to be somewhat lackluster. Now, in preparing this talk, I had some various thoughts. I thought, on the one hand, this would be a very easy talk, and it would be quite simple. At one point, I thought I would take the historic perspective and talk about lap chole and what happened with lap chole and the failure of many of the subsequent laparoscopic procedures to really get adoption. We could talk about practical issues. I mean, how practical is it that making a hole in the stomach is going to be something people are going to eagerly pursue for their cholecystectomy? There's a political angle and there's a financial angle. I even thought about talking about what do general surgeons do today and where in the world could notes ever fit in the armamentarium of a general surgeon today who's doing minimally invasive surgery. I even thought about being a little more provocative because, you know, we heard the review of notes in the United States and we heard about some activity in the Midwest, but frankly, most of what we hear about in the lay press, and it's coming from Southern California and New York. And I might argue that not much has come out of Southern California or New York that we should really pay much attention to in any area right now. And that alone could be the reason to say that this really isn't going anywhere. And I'm sorry, Drs. Talamini and Bessler and others, but all you have to do is look in the New York Times or Time Magazine to see some pretty interesting quotes about notes in those parts of the country. Well, I decided really to take a little more of a cerebral approach to this. And actually, Dr. Schweitzberg has set up many of my comments nicely, because when we think about what's it going to take for any new device, new procedure, new therapy to be successful today, whether it's notes, whether it's single port laparoscopy, whatever it is we're talking about, we have some critical factors that are going to be necessary for success and adoption. Clinical results, ease of use, patient demand, cost, reimbursement, and compelling other or alternate therapies and options. And again, Dr. Schweitzberg really set some of this up nice. And I'll even confess at one point I thought I would just sit in the audience, take notes about everything everyone else talked about, and then just come up and summarize it all and tell you that's really why this doesn't have a brilliant future to replace minimally invasive surgery. Well, if we look at clinical results, I think it's important to remind everybody what it really takes to get those good clinical results. Animal feasibility studies, survival studies, further survival studies for proof of concept. Then we get into human tissue, typically in an explanted fashion, then some short-term human survival to show safety, and eventually long-term data for efficacy. In this notes area, we have some feasibility, we have some safety in animals. We've kind of jumped right to the human application right now and are already doing some human safety and even suggesting efficacy. We saw some data today from other parts of the world where we're actually comparing notes to lap chole and apparently are having some efficacy data. All of this is very expensive, and when we talk about the expense of bringing new technology in, this is where a lot of the front-end expense is loaded. Ease of use is a big issue, and I think in notes, all of us would acknowledge that this is technically very complex. We're not sure how to do it, we're not sure who should do it, we're not sure how to train anybody else to do it, and we've acknowledged that there's a small subset of people who are doing this and can do it reasonably well. But the likelihood that that skill can be transferred to the rest of the surgical or gastroenterologic population, I think, is in question. The equipment necessary, where do you do it, all these things I think are going to be critical. What about patient demand? How big a market are we talking about? In lap chole, and I'll say something about that a little later, we had the killer app. If laparoscopy would have been first introduced and it would have been for any other condition except the condition and the procedure most commonly done by a general surgeon today, I'd argue that it would have failed. How understandable is this going to be for the patients? They like no scar, but when you get into the detail of telling them we're going to make a hole in your vagina or we're going to make a hole in your stomach, that's pretty understandable and not necessarily well received. Is this life-saving or is this simply cosmetic? How non-invasive or how less invasive than minimally invasive surgery really is it? Or are there market factors? Are we all in this room today because we think if we're not on board early, we may miss it and be left behind, like happened with lap chole for so many people? Cost is an issue, the cost of the expense, how much added infrastructure are you going to need, who's going to pay? Reimbursement, we heard about reimbursement. This is a huge issue. How long does it take to do it? Is it worth the time that you're going to invest to actually get reimbursed? We hear from many of our gastroenterologic colleagues that when they can do screening colonoscopies in a very short period of time with a reasonable reimbursement, they're not particularly interested in a 2-hour procedure that pays poorly. And then other therapies. And I think when we're talking about comparing notes to minimally invasive surgery, this is a significant issue. Is there some unmet need? Or is this competing head-to-head with another therapy that's very entrenched and very well established? What is it about this therapy that's going to be better? Faster, cheaper, safer, and you can't ignore the zero-sum game of healthcare that we're dealing with today. And I will tell you, in my opinion, and Dr. Schweitzberg I think touched on this, every new therapy we introduce to practice, the healthcare systems today have to decide where are they going to take the dollars to support the new innovation and the new therapy. Largely in a zero-sum game, they're going to take it from the doctors. And so we have to be really cognizant of that so that if we switch to a new therapy that requires a $2,000 piece of equipment, they're not going to add $2,000 to overall healthcare expenditure. They're going to take it from someone else, and so far they're taking it from the doctors. Well, recognizing that, and Dr. Schweitzberg did some of this already, so I'll go quickly. If we look at successes and we look at these parameters, and we start with lap chole, remember, lap chole we had no results. It was a complex procedure. It cost more. There was a lot of infrastructure cost to bring lap chole in. Reimbursement was okay early because the insurance companies had no idea what was going on. So they were paying, and we were actually able to use unlisted codes and even bump up our reimbursement at times. And there weren't other good options other than open cholecystectomy, and we all know the differential there in recovery and pain and perception that went along with that. But we had huge patient demand, and we didn't face these other obstacles of reimbursement. And lap chole was adopted, and we all know that story. If we look at Nissen, it's a little different story. Nissen comes along a little later in the timeline. Clinical results were good. Over time, as you got skill, it was fairly easy to do in Nissen, less than an hour procedure in skilled hands. Patients liked it. Cost wasn't too bad. We'd already built the infrastructure in lap chole, so there wasn't a lot of additional cost to bring in lap Nissen. Reimbursement, so-so, but there were other competing therapies, and that's what we're fighting today, is another compelling competing therapy. And Nissen is not widely adopted. Almost everyone I've talked to over the last couple of years has told me their Nissen practices are declining, and we're going back to patients being cared for medically. Let's go out of our space a little bit and go into carotid stenting. Clinical results have been okay. It is challenging to put a carotid stent in, and there are training issues and technical issues. Patients, however, like it. They understand it, and when told they can have this done through a percutaneous approach, they pursue it. There is some incremental cost associated. There is perhaps a reimbursement benefit, and there aren't very many other competing therapies. In other words, an open carotid endarterectomy is the competition. And carotid stenting in most places that I've been is widely adopted. Every vascular surgeon I know is doing it or scrambling to be able to do it, and it's being offered across the country. Colectomy might be another thing we could look at, and you can sort of scan down the column and see. In my opinion, I don't think lap colectomy is yet widely adopted. The adoption rates across the country look to be in the 20% range to 30% range at best. And it's some of the same issues that we see in a colectomy. So we also have heard a little bit about the promises of endoluminal therapy, perhaps as a surrogate to whether notes will really catch hold. Heck, endoluminal therapies are incisionless. It meets many of the promises of notes with less of the technical challenges. And we all know there were lots of contenders for the endoluminal therapy market. Now, these are people with good data or reasonably good data, mature devices, and established companies around these devices. And we all know what happened with these. If we scan down the list, we see that Strata had data, patient demand was there, higher cost, no reimbursement, great other options, failed. EndoCinch didn't have great data, it failed. Endio, most recent failure, had reasonable data. They all had the sham-controlled prospective trial data that was out there. Endio failed. Esophax is the next player that's coming into this, and we'll see. I personally think if Esophax can't answer the reimbursement question, it's not going to survive. And we've seen all these companies now who've entered the market or are thinking of entering the market, not surviving. So if we take this now and we apply the notes model or the notes concept, we have no clinical results, I think, that are reasonable to bring forward to say we can start using this widely. Ease of use, undeniably, we have seen some of the most talented gastroenterologists and surgeons in the world present their work and some of their videos at this meeting. Extraordinarily skills to do this. There may be patient demand, but I might argue that to sell a patient on a hole in their stomach or their vagina is going to be a hard sell. Obviously, there's higher cost. Reimbursement, we have no idea. Dr. Schweitzberg's talk was inspirational, and if we all marshal together and get the data and get behind that big rock that's looming above us, maybe we can push it to the summit. I don't think so. And we have compelling other options today. I don't think a notes cholecystectomy has a chance in the world of displacing a well-done laparoscopic cholecystectomy, outpatient procedure, done in less than 60 minutes, very, very low complication rate, and wide acceptance across the country, both by payers and by patients. Notes isn't going to displace that. So I'll kind of close, and I hope I'll close. You need the sound for this, and most of you have probably seen this. I hate to throw cold water.
I just thought you might want to know, sales aren't up, they're down. Yes, sir.
please don't make me dance.
Want a new job?
But I do want to leave you just with a couple of thoughts. And we've heard this over and over again. First, do no harm. And I point out that it's most often mentioned, this statement is most often mentioned when debating use of an intervention with an obvious chance of harm, but a less certain chance of benefit. And I think that is what we are talking about today. And I also ask you all, as I try to end my side of this debate, which would you rather have, a lap chole by a skilled surgeon or a transgastric or transvaginal cholecystectomy by a surgeon and a gastroenterologist, granted extraordinarily talented, but are still trying to figure this whole thing out? With that, I'll look forward to the counter position.